So cellular physiology, here's where it all begins. We're going to start out with cell organelles. Now, the most important cell organelle within a cell is the nucleus. How do you remember that? Because the nucleus has all your genetic material. The cell cannot live without genetic material. Within those genes is all the information about how to survive, how to repair itself, and how to live. So the cell organelle that no cell can live without is the nucleus. So that means if you want to damage a cell irreversibly, you damage the nucleus. Now, if you want to get that down to a vitamin, then that vitamin would be folate. Because without folate, you couldn't make DNA. Now, in the middle, or at least off to the side of a nucleus, is a small circle called a nucleolus. The nucleolus gives us only one thing, and that's called ribosomal RNA. Now, if you remember, there's two types of ribosomes. One we call free ribosomes. Free ribosomes produce proteins that stay within the cytoplasm. Just remember, free ribosomes are floating free in the cytoplasm. So when they make their protein, the protein breaks off and it's still floating in the cytoplasm. So, number one, free ribosomes make proteins that stay in the cytoplasm. If a test writer wanted to make that more specific, all he had to do was name a protein that functions in the cytoplasm, like the enzymes of glycolysis or pentose pathway or fatty acid synthesis and so many others. He could just ask you, where do you make this protein? Then you'd have to remember, oh, the pathway goes on the cytoplasm, and so that means free ribosomes make proteins that stay in the cytoplasm. Then we have rough endoplasmic reticulum. Those are ribosomes attached to endoplasmic reticulum. That's where you make proteins that need to be packaged to either go to another cell organelle or to go to another cell or tissue altogether. So the first most important cell organelle is the cell nucleus. Without it, that cell will die. Any damage to the nucleus means the cell will die. Well, there's two ways to look at this. So irreversible cellular injury can happen in one of two ways. Number one is called apoptosis. Apoptosis says it's programmed cellular death. Apoptosis, if you remember, it had a marker that we talked about in biochemistry, which was called phosphatidylserine. Phosphatidylserine was one of the phospholipids that we produce in biochemistry. And this is the marker for any cell who's going to undergo apoptosis. And if you remember, there was a group of enzymes called caspases that recognized that. Caspases recognize the phosphatidylserine. Well, they're going to bind to the phosphatidylserine. So where's phosphatidylserine located? It's on the cell membrane. This is how to remember in apoptosis, while the cell membrane will dissolve first. And that means the nucleus will dissolve last. And because this is programmed cellular death, there's no inflammation going on. So the cells go quietly because it's already been programmed in their genetic material that on such and such a day, they have to leave. If you remember the proteins that take you out of the cell cycle, we call them the decyclins. Decyclins will determine when it's time for a cell to be taken out of the cell cycle and then put the phosphatidylserine on their surface. So during apoptosis, the cell membrane will dissolve first, the nucleus will dissolve last. Because it's programmed cellular death, there's no inflammation involved. There are three words that you need to understand that tell you that the nucleus is irreversibly damaged. Number one is pycnosis. Pycnosis, just think about it. You pick your nose, you come out with blebs. So on the boards, they'll describe to you what's going on with the nucleus, and you have to pick the right term. So pycnosis says that nucleus forms blebs. Karyorrhexis means the nucleus breaks up into chunks. And then karyolysis means to dissolve, is when the nucleus actually dissolves. So any one of these three terms means that the nucleus is gone, which means the cell is irreversibly damaged. There's no way to bring it back. So this is apoptosis. What about the other side? Necrosis. In necrosis, this is unexplained or unforeseen cellular damage. In this case, if you want a cell to die immediately, what do? Attack its nucleus. So in necrosis, the nucleus dissolves first. And because this is unexpected, it's going to involve inflammation. That means the cell goes kicking and crying and screaming, and so the body has to go over there to find out what's going on. And we've already talked about inflammation several times. The neutrophils are going to be your first line of defense. All right, they're going to start coming into the area around 4.5 hours. Remember our stroke literature? and then predominate at 24 hours and peak at day 3. You're going to get the same 3 words. Pyknosis, the nucleus forms blebs. Karyohexis, the nucleus breaks up into chunks. And karyolysis, the nucleus dissolves. The only difference is in necrosis, the nucleus dissolves first. In apoptosis, the nucleus is going to dissolve last. So in other words, the way to look at it is apoptosis is an implosion. That means you start on the surface and come inwards. Whereas a necrosis is an explosion. You start from the middle and go out to the periphery. So that means apoptosis is scheduled cellular death. Necrosis is unscheduled cellular death. Now, that means if I see a tissue that's there today that was supposed to die yesterday, and I ask you, how come it's still there? You say, well, apoptosis did not occur. And I say, well, what if I saw 1,000 cells that are still here today that were supposed to dissolve last week? And I ask you, how come they're still here? You say the same thing. Apoptosis did not occur. What if I expand it to say, well, what if you had an extra finger on your hand, as in polydactyly? And I ask you, how come that finger is still there? How come it didn't go away months ago in gestation? You say, aha, apoptosis didn't occur. What if you have a membrane in your esophagus and call it esophageal atresia? And I ask you, how come that mucosa did not dissolve? Why did it not go away in development when it should have gone? You say, okay, apoptosis did not occur. I can ask you the same thing about duodenal atresia. I can ask you the same thing about syndactyly, when the membranes between your fingers never dissolved. So in other words, by understanding apoptosis, look what we've done. We now can explain every atresia anybody can ask you. You can explain polydactyly, syndactyly. You can explain 1,000 diseases where tissue is still there and it was not supposed to be there. So if you have a skin tag, something that simple, and they ask you, how come this skin tag is still here? Why didn't it go away? You say, oh, okay, apoptosis did not occur. If they want to get it down to a marker, you say, well, maybe it wasn't labeled with phosphatidylserine. So there's a lot of ways to use the information. Another example is supernumerary nipples, a child born with multiple nipples. Well, the other nipples were supposed to dissolve and go away. And so that means if that baby is born with 3 nipples on one side, and they were to ask you, how come those nipples are still there? You say the same thing. Apoptosis did not occur. So notice as we learn a piece of information and understand it, we can then apply it to 1,000 different situations. So phosphatidylserine is the marker for scheduled death, and it is recognized by the enzymes called caspases. So that's the first important point we've just learned. Now let's just focus on necrosis itself. Necrosis, what's the definition? Unscheduled or unprogrammed cellular death. What's going to disintegrate first? Remember the nucleus. And if they want to get it down to a vitamin, which vitamin do you pick? You say folate. All right, the most common type of necrosis is called ischemic necrosis. That means the most common cause of unscheduled cellular death is called ischemia, or coagulative necrosis, meaning that the blood supply got taken away. Coagulative necrosis means the blood supply got taken away. So ischemic or coagulative necrosis is the most common type of necrosis. It is also the most favorable type of necrosis. Why? Because even though some tissues died, the architecture of the organ is still maintained. Let me give you an example. If you have a stroke and I ask you what's the most common type of stroke, you say an ischemic stroke. And I say, well, does it have a good prognosis or not? You say, well, it has a good prognosis. Why? Even though you've destroyed some brain tissue, the rest of the brain still looks normal, so architecture is maintained, which means function should return, which means other areas will pick up on that function for you, or at least most of the function should return. So ischemic necrosis is the most common type of necrosis. Remember that. Purulent necrosis means pus. Think bacteria. So whenever you see purulent necrosis in any vignette, think bacteria. Can viruses be purulent? Sure they can, but just don't pick it on the task. Can protozoa be purulent? Sure they can, but just don't pick it on the task. If they say purulent, the most common reason is a bacterial infection. Pick the bacteria. That way you get the point the majority of times. What about granulomatous? Granulomatous inflammation, or granulomatous necrosis, means T cells and macrophages are involved. And if you remember, if T cells and macrophages are involved, that means cell-mediated. Well, what do you expect when you see cell-mediated? Remember, non-bacterial, starting with viruses, then fungus, then mycobacterium, and so forth. So that means granulomatous simply means don't pick a bacteria. Can some bacteria be granulomatous? Sure they can, but just don't pick it on a test. All right, bacteria we pick here are purulent. Granulomatous is anything that's non-bacterial, starting with viruses, then fungus, then mycobacterium, protozoa parasite, Campylobacter disease, and neoplasia. All right, so granulomatous inflammation. Next is fibrinous. With fibrinous necrosis, the first thing you ought to think about is that there's fibrin deposition. Whenever there's fibrin deposition, it looks like little pieces of wire sticking out of endothelial cells. So if you got wires or like needles sticking out of endothelial cells, then when the red blood cells and platelets go by, then the needles will shear them into pieces. Those are called schistocytes. Sheared red blood cells and platelets are called schistocytes. And anytime you have schistocytes going floating around, what kind of disease process do you have? It's called vasculitis. So whenever they use the term fibrinous, think vasculitis first, think uremia second, that means severe renal failure, and then think tuberculosis third. So fibrinous, vasculitis first, uremia second, and then tuberculosis third. Now when you hear caseous, the next one, caseous simply means cheesy. And caseous means only one pathogen that they want. They want tuberculosis. So notice, therefore, some words are specific, some are a little more general. So tuberculosis could be granulomatous because it's not a true bacteria. It could be fibrinous, but it falls into third place. But when you say caseous, then it falls up to first place. So again, the key is to organize your thoughts so that whenever you use key words, immediately a differential pops into your head. What about fat necrosis? Fat necrosis occurs in organs which are primarily sitting on a bed of fat. First one is in the abdomen, the retroperitoneum, the pancreatitis. When somebody suffers from pancreatitis, first of all, hypertriglyceridemia inflames the pancreas. And then when you get pancreatitis, because it sits on retroperitoneal fat, it inflames the bed of fat behind it, and then you get fat necrosis again. So hypertriglyceridemia causes pancreatitis, and then pancreatitis causes fat necrosis. So fat necrosis in the abdomen, think pancreatitis. The second location is blunt trauma to the breast. Because the breast is made up of mostly fat, any blunt trauma will cause fat necrosis. So typically though, when a woman comes in with fat necrosis of the breast, significant blunt trauma has been applied. Typically, you have to worry about a battered woman. There was an article many years ago that gave it a special title called The Hidden Second Diagnosis, meaning that the battered woman comes into your office with all kinds of nonspecific complaints. But if you're watching her body language, you can pick it up. First scenario is the woman who comes in with her husband, but her husband is doing all the talking. So the husband's doing all the talking. She's not allowed to say anything because that's the way she has been fearfully put into that state that she doesn't say anything unless he allows her to speak. What you have to do as a physician is ask him politely and respectfully to leave the room so that you can speak to the woman, because that's the only way you're going to get the truth or get down to the truth about what's going on. Now, there are times where you may run into a couple from a different country and they're trying to tell you that the man must do the talking for the woman. But you have to tell them that here in America, the woman must speak for herself. And you cannot bear the liability of treating a woman with only the history from the husband. So if he refuses to leave your office, or leave that room, then you have the right to say that you cannot treat the wife or the husband. But it's very important to get the woman alone. Second clue is that the woman keeps looking down at the floor the whole time you're talking to her. She never wants to look in your eyes. She avoids all eye contact. Why? because she's been slapped so many times for looking her husband or boyfriend in the eye that she's afraid to look any other man in the eye. So watch out for that. Then the other thing that you'll notice is that when you examine her and you find the fat necrosis and you ask her how she got it, she always makes up a real quick story about how it happened. She'll just tell you something simple like, oh, she was just reaching a cabinet trying to get something out of the kitchen cabinet, and a can of soup came and hit her on the chest. She'll make up something very quickly. And you and I know a simple can of soup hitting the chest is not going to cause this. But she wants you to believe that. Now, they tell you, do not get yourself involved in some domestic battle, because she's an adult and she can leave anytime she wants to. But what we try to do is get social services involved, meaning social services will give her the information about how to leave that situation. Now, there was a study done many years ago that showed if a woman leaves a battering relationship, leaves a husband or a boyfriend that batters her a lot, and returns back to him, there's a good chance she's going to be dead in the next 30 to 60 days. It was a nice retrospective study that showed women who got killed by a very violent husband or boyfriend, she tried to leave him in the preceding 30 to 60 days. Typically, when she comes back, he feels remorseful about everything, but then after a while, he gets very violently jealous. They're very, very jealous people and very, very violent. So even policemen are told to stay out of this situation. Let social services handle it and give them the information about how to get free legal help and protection until the court date for her to testify against him. So fat necrosis of the breast. Think blunt trauma to the breast. Think a battered woman. And then hemorrhagic necrosis. Hemorrhagic necrosis occurs in any organ where you have 2 or more blood supplies. Now, whenever you talk about 2 or more blood supplies, it sounds like that should be a fantastic thing. 2 or more blood supplies, like in your lung. You got the pulmonary arteries, you got the bronchial arteries. In the GI tract, tons of blood supply. In the liver, portal vein hepatic artery. So the brain has more than one blood supply. Vertebral artery and carotid arteries. So anytime there's 2 or more blood supplies, then necrosis can be hemorrhagic. Now, here's what can happen. If you slowly deprive a tissue of its blood supply, then the opposite side can make up for it. Or you can start to grow collaterals. If you remember, collaterals are just blood supply that come in and go around the clot. So let's say you develop a clot in an artery. So let's say I'm right here in the middle, and I'm the tissue. And then I got a blood supply coming in here from the right, and I got blood supply coming from the left. So I get 50% from the right, 50% from the left. Well, it turns out if you have the tissue drop its nutrition requirements or oxygen supply less than 0.9, that means less than 90% of what it needs, that tissue will start to feel effects of ischemia. So we're not even talking about, when it drops to much less than that. So that's the reason why when you have, like, somebody has peripheral vascular disease and they tell you to do an anchor-brachial index and it drops to 0.9 or less, that's when you know somebody has true peripheral vascular disease. Well, typically when you drop below 70%, then necrosis starts to occur. That's why when you have peripheral vascular disease and anchor-brachial index drops to 0.7 or less, then you have to try to revascularize that area. All right? So again, it's just applying what we are learning. So hemorrhagic infarct. So let's say you start to clot off the blood supply from this side on the right, and you do it slowly. It turns out that when you drop to about 0.9 or less, what will happen? The tissue here in the middle will start releasing angiogenin. Angiogenin will start to stimulate new blood vessel growth. These are called your collaterals. Collaterals are new areas of blood flow coming into the same area. So therefore, as blood supply decreases, collateral flow will provide that blood supply, So that means the tissue in the middle, me, I don't suffer at all. So on the test, what do? They give you a process that is slow by nature. And this process will be called atherosclerosis. So that means they'll simply ask you, what would happen if you had atherosclerosis of the right carotid artery and it falls to, let's say, even 100%? You've lost all the flow from the right carotid. And they'll ask you, well, what's going to happen to the right side of the brain? The answer is absolutely nothing. Somebody did a nice retrospective study. It was an autopsy study where they took people who died in car accidents and they dissected their carotids and they found people who had complete occlusion of one carotid artery. And for those people, they reviewed their medical charts and found the majority had no history of TIAs or strokes at all. Why? Because you have a circle of Willis, which means as you lose blood supply from one carotid, circle of Willis will furnish blood supply from the opposite side, and therefore you got collateralization without any incident. All right? So notice why they picked atherosclerosis, because atherosclerosis is slow by nature. Now, what about the opposite? What if you quickly cut off the blood supply? Now, that's different. Quickly cutting off the blood supply is thromboembolic disease. So what if I were to throw a clot from the carotid right up to my brain? Well, the problem is you've just thrown a clot and lost, boom, 50% of blood flow to this tissue is gone. That means the blood flow, nutrient requirement, that means oxygen delivery, dropped to 0.5 in an instant. And I told you necrosis starts when it drops to below 0.7. So that's why embolic phenomena causes immediate cellular death to begin. And so the problem is this. When you cut off the blood supply, then the tissue here will start to necrose. And if the tissue starts to necrose, that's going to cause inflammation. When do the neutrophils start to show up? Remember, they start to show up around 4.5 hours. Predominate at 24 hours, peak at day 3. Think of the stroke literature. In the stroke literature, it tells you that if a patient has an acute stroke and comes in within 4.5 hours of that stroke, you can give them IV TPA. Why are they saying that? Because if you cut off the blood supply from one side, if the neutrophils don't show up at least for 4.5 hours, then you have 4.5 hours to remove that clot. If you remove that clot before 4.5 hours, then there's no neutrophils waiting, which means there are no free radicals waiting. Well, what if you waited till after 4.5 hours? Once the neutrophils show up, they start producing free radicals. Now remember in immunology, NADPH oxidase produces free radicals. So once they start producing free radicals, now if you remove the clot, free radicals come into the area, the tissue, and destroy everything in sight. That is called reperfusion injury. Reperfusion injury, that's even worse than the original injury. Why? Because free radicals have no friends. Free radicals pierce the cell membrane, then pierce the nuclear membrane, then bust up the DNA into pieces. Now a cell only has 2 choices left. Number 1 is to die. Number 1 is to mutate. Take, for example, when you give somebody radiation. Radiation is nothing but free radicals. How do free radicals from radiation do damage? Well, you're hoping they're going to pierce the cell membrane, pierce the nuclear membrane, and bust up the DNA into pieces. And that means the cell will die, so i.e. the cancer will die, or the cell will mutate. This is why radiation can also cause new cancer in the future. So notice concepts don't change. The key is for you to learn these concepts and understand them. So hemorrhagic necrosis occurs primarily when you have 2 or more blood supplies. The key is to undo the clot before 4.5 hours.